The Agenda with Steve Paikin is made possible through generous philanthropic contributions from viewers like you. Thank you for supporting TVO's journalism.
In the next 2+ decades, those over age 65 will make up 1 in 5 of us in this province. Tonight, how that's already creating some interesting new living arrangements. NORCs, for example. What's a NORC? Stick around and find out. We'll also hear what rural municipalities have in mind to help older adults stay in their communities as they age. Plus, what the World Health Organization said this week about whether the COVID-19 pandemic remains a global public health emergency. It's Wednesday, February 1st, and that's all ahead on the agenda. Perhaps some of those near and dear to your heart live in a NORC, N-O-R-C. Perhaps even you do, but don't yet know that's what it is or could be. NORC stands for Naturally Occurring Retirement Communities, and it's an idea that's catching on here in the province. Let's find out more with Dr. Samir Sinha. He is Director of Health Policy Research at the National Institute on Aging and Director of Geriatrics at Sinai Health and the University Health Network. And it's always a pleasure to have you back in that chair on our program.
Thanks for having me, Steve.
A NORC, Naturally Occurring Retirement Community. What is it actually?
Yeah, you hear that acronym and you're like, what exactly is that? And you realize you probably live in one. So we're talking about buildings or communities where more than 30% or a similar percentage are over 65 years of age. So you can think of an apartment building that many people moved into many years ago when they were in the youth of their life, and now they've ended up retiring there. And so these are almost, communities where they're full of older people, people who are still active and engaged and want to stay independent for as long as possible in their own homes. And so when you have this concentration of older people, it's a really neat opportunity to say, hey, are there ways in which we can start delivering services and other supports in different ways that can actually support, say, the healthcare system, but also the social and well-being of those individuals as well?
Does it have to be as big as an apartment building or a condo, or could it be, say, a few houses in a neighborhood or a townhouse row or something like that?
Absolutely.
Yeah.
I mean, like if you actually look across Ontario, Prince Edward County is what I'd call a NORC, because over 30% of its residents are actually 65 and older. But you could think of an apartment building, you could think of a group of houses, you could think of a mobile home park, for example. There are lots of places where we've seen a naturally occurring group of older people, and it's something to celebrate and support.
So this does happen organically as opposed to planned years in advance?
Very more so. I mean, sometimes there are seniors communities, for example, where you're definitely trying to attract, and even some cities like Elliott Lake in Ontario, they're actually trying to advertise themselves as an ideal retirement capital. But they're not necessarily, these aren't nursing homes, these aren't retirement homes, these aren't places where there's specifically care being provided and people are going for that aspect. These are just neighborhoods or dwellings where people happen to cluster and gather for a lifestyle reason, where it ends up happening to be more geared towards older people.
But you say they are organized in such a fashion so that there are sort of communal services provided, that type of thing. How are they organized?
Well, so they're not organized. This is the idea. So right now we talk about NORCs, that they just exist. So we start looking around saying, oh, I actually live in a NORC, for example, or I can see this community becoming a NORC over time. We have an opportunity to pair those NORCs with NORC programming. So the idea where older adults, if they want to collectively get together, say, hey, let's all pool a bit of money together, and then, or let's pool our time and energy together to create shared activities that we enjoy. So maybe we'll now have programming around things that we want to do together as a group. Maybe we want to pool our money together to maybe pay for things, entertainment or other supports and services that support our social well-being or even our care needs. And it's also an opportunity for governments that may be providing home care services and other supports to say, heck, if we actually start clustering the care and organizing care more effectively and efficiently in those settings, we can deliver more care and better outcomes in those environments as well.
Is it, in fact, better for seniors to be clustered in this way? Or is it better for them to have multiple demographics in the same space?
I think I think it's a little bit of both. I think people don't necessarily want to move and be in an environment where there's only just the same type of people. So again, when we think about, you can live in a retirement community, you can live in a long-term care home where it's generally older people, but multi-generational communities have massive benefits when you have young and old living together, interacting. We know that people really get a lot more out of those environments. But again, when you have a community where it's just naturally grown to having more older people, it's just thinking about what's the programming we're offering. Are we now thinking about the unique needs that older residents might actually have there? And so how do we start thinking about the services, the supports, what the building, for example, or the community might be providing, like transportation services, maybe supports with groceries, maybe programming or space where people can do exercise and falls prevention programs, and other things that would be an interest and support for those older people.
What's the average age of people who live in NORCs?
It can vary significantly. We generally say choose a percentage of how you want to define your NORC. Generally, we like to say 30% or above. And if you look at that, what does that translate? In Toronto, we have about 500 apartment, condo, and other buildings that we classify as NORCs. Across Ontario, about 2,000 buildings, if you will. And that represents 217,000 people who are living in these NORCs, if you will. And if you want to compare that, we have about 75,000 older adults living in long-term care homes and about 56,000 living in retirement homes. So this is a massive population that's gone unrecognized, and there's an opportunity to do something more interesting in supporting of these communities.
Is there a NORC that people would know? In other words, a particular neighborhood or a name of a place or something that you wouldn't have thought of was a NORC, but it actually is?
So I often joke that when I moved to Toronto and I work at Mount Sinai and the University Health Network, so I would start getting consults and I do home visits, and I'd often find myself in a building on Bloor Street called the Manulife Center. Many people know of it, and I'd say, and I'd talk to one of my very first patients, 100 years old, and I'm like, when did you move here? He said, I moved here about 40 years ago. And he's like, here I am. And all of his neighbors, and they were all older people. And I thought, and I said, look, why do you like this building? He's like, this building's great. I got a movie theater in it. I've got groceries. I got a liquor store. I got a pharmacy. I've got everything you need without having to leave the building. And what's really cool is when I go and visit people there today, friends or sometimes patients, I always see on the walls, that the community has self-organized. So they have like various nights where they're playing cards, watching movies, doing other things. That's a NORC where that's self-organizing. Nobody's coming in and doing things to that community. That's a community that's recognizing, this is what we want to do to support our older residents, and this is how we want to make life even better.
It never occurred to me that the Manulife Center is a NORC.
Absolutely.
And it's been there, I don't know how long it's been there, 50 years, 60 years, it's been there for a long time. It's right in a subway stop, so you got mobility as well if you need it. No kidding.
Yeah.
That's a NORC.
Exactly. And when you start thinking about it, wherever any of the viewers are kind of like, wait a minute.
It's a Bay and Bloor in Toronto.
Yeah, that's Bay and Bloor in Toronto. But when you start thinking about whatever community you're living in, you're probably like, actually, that's a NORC, that's a NORC. Actually, we're in a NORC. If you're living in Prince Edward County, you're in a NORC.
Okay, urban or rural, where do you see more of them?
You tend to see more of them in urban communities in terms of like where you see kind of single buildings, for example, or maybe a neighborhood where you actually see a cluster of older people just due to shifting demographics over time. But as I was saying before, in rural communities, we know that they're aging much faster than, say, urban communities because we have a lot of younger people who might be going to the city for various opportunities. So therefore, these rural communities tend to age much quicker because it's just mostly older people living there. That's why we see, when you look at communities that are actually entire communities that are NORCs, we tend to see more rural communities as opposed to urban settings like Toronto or Hamilton or Ottawa that tend to be younger than the average age of the population in Ontario.
Now, I would have thought it might be difficult to kind of organically be in a NORC in rural Ontario because, of course, access to medical care in rural Ontario is a lot tougher than it is in urban Ontario. So is that a big challenge if you're trying to imagine a NORC in rural parts of the province?
Yeah, so you have to look at each kind of NORC, if you will, and look at its assets and also look at kind of the challenges. So you have a natural group of people who happen to be older. You have to think about the services that they might need, especially if you might have mobility needs, if you may need help with getting around your community, so you might need transportation supports and other things. And we think about access to care and access to health care. So in urban areas, that might be easier to actually organize the healthcare piece and the home care piece and even the transportation piece. But if you think about a rural community, you need to think about transportation. You need to think about ways in which you can deliver care differently. And that might be using more virtual care methods or other things so people can age in those places for as long as they want to as well.
But to be clear, this is nothing that a person can decide to go set up, right? Someone doesn't say, I'm about to go organize a NORC. It either happens or it doesn't?
Yeah, it happens or doesn't. So you can imagine a building where over time it just happens to have a lot of older people, and then with time people will pass on, and then those apartments might fill up with younger people. And so a building, for example, or a community can go through these ebbs and flows. It's more the idea of thinking about, wait a minute, this community is now a NORC. There's an opportunity here, and it's an opportunity for people to actually say, well, now that we recognize this unique opportunity, how do we want to organize, ourselves, and what services do we want to create to enjoy our lives? And even for governments who are providing healthcare services to say, maybe we could deliver care more efficiently in that setting where we have a high concentration of older people and an opportunity to do things differently.
Play that out if you would. For example, what kind of medical care, if you have a certain cluster of people, could you imagine coming into that building or into that row of townhouses that would be appropriate for a NORC that you might not otherwise have?
So I'll give you two examples.
Sure.
So when we were doing the COVID vaccine rollout here, we wanted to make sure that we got to older people as soon as possible, and especially older people in more vulnerable communities, especially low-income communities. We used our magical map. We said we've got 500 NORCs in Toronto. We were able to look at those that were in more disadvantaged parts for equity-deserving communities, and we made sure we sent our paramedics to those buildings first, and we rolled out the vaccines in order from an equity standpoint. That was a great way to hit a high concentration of older people and those who needed it before others. Another example is that often when we're delivering home care services, we sometimes have multiple different agencies providing home care, and sometimes multiple different agencies going to the same building with a bunch of different workers. But if we've got a lot of people in this building who need home care, you might just reorganize it so you have one agency responsible for that building with familiar individuals. You get better employment opportunities because you have a few full-time staff who just kind of live in that building, if you will, provide care. It promotes more relational care, if we say, and it's more efficient because you don't have someone going to this building and then going to that building. They can just concentrate the care, deliver it more effectively. And when we've actually done those models, we see better outcomes and more effective use of our precious home care resources.
So it still, at some level, requires a small number of people to kind of take the bull by the horns and, have the leadership to say, here's what I think we are, let's set something up. Is that
Absolutely.
right?
We talk about this idea of participatory decision-making. Sometimes we live in buildings where nobody wants to talk to each other. That's not a good starting place for a NORC. But we have some where we have people who say, yeah, we want to do this. We like our community. This is what we can do. So it revolves around the idea of having people interested. And there's a cool place called the NORC Innovation Center through the University Health Network that's creating something called the NORC Ambassadors Program, allowing people to gain skills so that they can be ambassadors to help get their co-residents on board to say, what is it that we want to do? How do we want to self-organize? But there's another level that we're saying to governments that might be delivering healthcare services to say, if you have an opportunity to deliver care more efficiently and effectively that saves both the taxpayer money and actually delivers better care outcomes, wouldn't you want to do that if you had this opportunity in front of you?
Why wouldn't you do it? Okay, in our last minute here, you say there's 2,000 NORCs in Ontario. How do you know? Do you register somewhere to show that you're a NORC, or what? How do you know this?
No, we just happen to know the demographic information when we fill out census forms and other things. All that information is available, so we can actually look at great data sets to say, that's a NORC, that's a NORC. And that way you can use a bit of science to determine where these communities are and the opportunities to engage with them to see what more we can do.
Okay, so there's no place you actually have to go register. You just become.
You just become.
Becoming a NORC. not a NARC. That's a different thing.
Totally different thing. We're not going there, Steve.
NORCs. Okay, Dr. Sinha, as always, we're grateful for your time. Thanks for coming into TVO today and explaining what a naturally occurring retirement community is. Thank you.
Thanks for having me.
The median age in Ontario is more than 40 years old, which is not all that young. And in rural parts of the province, the number tends to be higher, often much higher. At the just completed 2023 Rural Ontario Municipal Association Conference, officials shared strategies for making communities work for residents as they age and look for more support in their senior years. And we're joined now by two such officials. Noelle Reeve is a planner with Tay Valley Township, that's in Eastern Ontario, and Jane Sinclair, General Manager of Health and Emergency Services at the County of Simcoe in the Barrie area of the province. And it's good to have you two here. You both came a long way to be with us today. And it was hell, I imagine, right? How long did it take you to get here?
Took me a couple hours to get here.
2 hours to get here, and it should take one.
Probably 1.5.
One and a half?
A little bit longer.
Okay.
Pleased
how'd
to
you
be
get
here.
I got here by train and taxi.
Train and taxi, not too bad.
Yeah.
Well, we're glad you're finally in those chairs. Tay Valley Township. I think it's, okay, if memory serves, if you draw a line between Kingston and Ottawa, it's sort of right in the middle. Is that
It
about
is.
right?
Yes, it is.
Okay, how big an area is it?
So it's 555 square kilometers, but what that means, if people are trying to figure that out, is it's about the size of the city of Toronto, so not the Greater Toronto Area, but the city
Just
of
the 416.
Toronto. Yep.
Okay.
But we only have 6,000 people, so that's kind of like the population of Centre Island.
Okay, so it's the size of the 416, but instead of 2.8 million people, it's
6,000.
6,000 people. Okay, that's different. And how about yours?
So we're a large population, close to 500,000. But it's a very large geography. It's about an hour and a half north of Toronto. And we have 16 member municipalities plus 2 urban centers, the city of Barrie and the city of Orillia. So lots of population spread across a huge geography. I think we're the second largest county by land mass in the province of Ontario.
Behind what? I don't know either.
I think Renfrew.
Oh, is that right? Okay,
Yes,
in Eastern
yes.
Ontario. Okay, very good. Any idea what percentage of your population are seniors?
Yes. So we have a very skewed percentage of that population. So 55% of our residents are 55 years and older. And the average for the province is 33%. So you can tell we are really skewed towards having far more seniors than the rest of the province.
You are a little disproportionately older than the rest of the province.
Yes.
Okay. Is that good? Is that bad? Is that what is that?
It's good in the sense that we have a lot of residents with wide ranges of experiences, so they can share their experiences with us. It's not so good when you think about a vulnerable population. And, you know, some seniors are fine on their own, but some seniors, just like the rest of the age groups, need more help. So it can be a problem for us to make sure our residents are able to stay where they want to stay in our community.
Gotcha. How about Simcoe County? Any idea what percentage is senior?
Absolutely. We're 19.9% 65 plus, so we're above the provincial and the national average. And again, a great history, great culture, but lots of challenges for our senior population because much of the communities are small, rural, and really spread apart across the entire region. So present some challenges for our aging population.
Why do seniors like to live there in disproportionate numbers if there are so many challenges with regards to access to services and appropriate housing and all of that?
I think that's part of our great, a very rich history in the county of Simcoe. We have a lot of farmland, a lot of farmers, and small municipalities that have been here for, you know, over 100 to 150, 200 years. And so they're very proud of that heritage and their culture, and proud to live where they are. And so we're working really hard to ensure that they have all the services and amenities so they can continue to live in their homes within the county.
So you have multiple generations of people who came maybe a century and a half ago and have just stayed.
Very much so.
Huh. How about in your experience?
It's pretty much the same. We have a lot of farmland, a lot of rural areas, but we do have, fortunately, amongst some of our seniors, researchers who work with the Rural Ontario Institute, and they've looked at why young people leave. So it's kind of the opposite side of the question. And I thought it would be the lack of employment opportunities, but really it's the lack of the housing that young people want. So not enough apartments, condos, small houses, and also not enough amenities that they want. So not enough opportunities to go out to a bar or to go dancing, to a club, or even just, go to a maker space and make something together. So it's interesting when you talk about why you have a lot of seniors, you also have to look at, well, why is your youth leaving?
Okay, this is going to sound like a really dumb question. Do you have a movie theater in your community?
No.
Do you have a nightclub or something like that in your community?
No.
So, okay, these are things young people like to do, and
yes,
there you go.
Yeah.
Any chance of either of those things happening?
Well, we did have a drive-in open nearby, which was
cool.
exciting. Yeah, the nightclub, I know some of the young people would love to do it, but, they need, I guess, venture capital. They don't have the money to do it.
Right. Okay, your township's been working on something called an age-friendly community plan for several years now. What does that look like?
So the World Health Organization actually identified what an age-friendly community was a while ago. And they said that it's a community that supports its older people, so both physically and also socially. And then the province came along with a program, Age-Friendly Communities, and defined it in a different number of areas. So housing, transportation, healthcare, outdoor recreation. And so we have a sort of a template from the province, a guide, so that you can look at your community and say, how are we doing with our seniors? And we can do a survey and ask them, do you have the supports you need to stay in this community, or are you thinking of moving to a more urban area? And we don't want them to move to the urban area.
Right.
So we then plan for what they say the gaps are.
So where are you in the plans right now?
So we completed an age-friendly plan a couple of years ago, and we are just starting to implement it. So we're just starting to focus on 3 areas of that plan.
And they are?
Co-housing, communication, and seniors inclusion.
That last one's big, isn't it?
It is.
Yeah.
It really is.
They got to feel like they're part of something.
Absolutely.
Connected to something.
Yeah. One of the things that turned up in the survey was that older men were really suffering from mental health, lack of mental health. So, just feeling incredibly isolated and I guess not feeling comfortable reaching out to let people know that. So that was, one of the social supports that the survey turned up.
Jane, how about you? You got something similar going on where you are?
Very similar. We modeled after the World Health Organization. They define it as 8 domains, so housing, transportation. And we did a huge engagement study. In 2017, we were very fortunate to receive some seed funding, a grant through the province of Ontario. We surveyed over 3,000 seniors across the region, plus a number of other types of one-to-one and group interviews. And we identified the top priorities for our seniors, our aging population. And from that, we put together a whole strategy. And the strategy currently is from 2018 to this year, 2023. It contains over about 135 specific action items. And this year, we're getting ready to do a refresh to go out to our seniors and say, how do we do? The activities that we put in place, some of the strategies, are they working? Are they helping? So we're excited about that next step in our process.
If you've got a to-do list with 135 things on it, how many check marks are on that list right now?
Surprisingly, this is very much a team focus. So at the County of Simcoe, it's a large corporation. We have many departments, and so it's not all myself and a few folks. There are many individuals working on this, and we've achieved some amazing action items. One I might just mention quickly, housing. It's one of the key areas, and the County of Simcoe started a housing grant for aging population, $500,000 annually. Seniors across the region can apply for modifications to their home, so to make it more easy to live there, grab bars, ramps, different types of features so they can age in place literally. And we've provided grants to over 200 seniors across the region to date.
200 homes or people?
Individuals.
Individuals?
Yes.
Okay, is that, I don't know, is that Is that much uptake or not much uptake or what?
It's great uptake. Actually, when we first started the program a few years ago, it was getting the word out, reaching the seniors so they know about this grant and so they can look at how we can help them to stay in their homes. And so every year we get more and more individuals that are applying for the grant, and we've seen some huge success stories for our aging population.
Because I presume they're probably, well, I don't know, I should ask. Are there many long-term care homes or alternative living arrangements in your county? Because I imagine if you've been living in a big home most of your life and then suddenly you find yourself 75 years old and maybe not as mobile as you used to be, your alternatives are presumably not as great as they would be if you were in the city.
There's 26 actually long-term care homes in our catchment area. But I have to tell you, so that is one option, but that's not the only option. And at the county, we've developed, we call them campus of care for seniors. And so there's a long-term care home. Our largest Georgian village in Penetanguishene has 5 different types of housing. It has retirement living, it has affordable housing for seniors, it has life lease, apartment, market rentals, and townhomes. So individuals with various needs in our communities have different options. It's co-located in one spot, one-stop shopping, so to speak, so they can live independently, but they have access to different fitness amenities, different service providers, et cetera, on this campus continuum. And we're just embarking in creating another even larger continuum in the southern part of the county of Simcoe. So some exciting options for our aging population.
Because presumably the idea is, let's keep them here as opposed to have them leave the county and go somewhere else.
Absolutely.
Got it. Okay. You want to take us through some pictures? You've given us some pictures here. We got a bunch here. Sheldon, let's take this look, because there are a bunch of different types of homes that you are offering in Tay Valley Township as well. Okay, let's bring the first one up here. And this has got, now, we got some people who listen to this program on a podcast and they won't see the picture. So I'm just going to describe what looks like sort of a series of two-story homes, but there's some windows that have got orange coloring around them, and that refers to what?
So the province allows for homeowners to have what's called an accessory unit. So what you're looking at is, with the orange, there's an accessory unit you could put in your basement. You could put an accessory unit above a garage attached to your home. You could put the accessory unit simply attached to your home. And what's not shown in this picture is you could even have a standalone accessory unit, what people used to refer to as granny flats. Sometimes people call them coach houses now. So that's what you can do now under the province. What resulted from our survey was that our residents wanted to do co-housing. And co-housing looks like other buildings, but it's an intentionality of living together and taking care of each other.
Okay, I think we got a shot of that too.
Okay.
You want to do, Sheldon, you want to bring this up? Okay, I think that's it there. Now again, for people who are listening can't see, we've got basically 5 homes in a row. They look like, what are they, bungalows or two-story? I can't tell.
Oh, they're little tiny, almost cottages.
Okay.
Yeah.
And they're all very cute Art Deco, different colors. And this is a co-housing situation because why?
So this is one model where people essentially in these little cottages would have their bedroom and a bathroom and a small living area. But the intention is that they also share a larger communal kitchen and a communal living space, so that every morning they see each other. If someone doesn't show up for breakfast, maybe they slept in, but if they don't show up for lunch, someone's going to go and check on them.
Okay.
And that's what makes the co-housing way of life, that people are committed to checking on each other.
Gotcha.
And there's lots of ways to do it, under condominium law, under co-op law, under joint tenants, under shared ownership. And the township doesn't really care how you finance it. We just care about allowing those 6 units on the property, which we don't right now.
Sheldon, can I see that shot one more time? It looks like, okay, everybody's got their own space, but then it looks like everybody sort of shares a big backyard. Is that right as well? Everybody's sort of responsible for pitching in and keeping it landscaped and beautiful and people, and they do that.
Oh, yes, and they want to do it. I mean, this type of housing exists in British Columbia. It exists widely in Europe. But in rural Ontario, there's a number of challenges to it.
Such as?
Mostly the fact that we are on septic systems. So people in the city might look at that and think, well, what is the challenge? You know, you just have your water pipes, your sewer pipes. You can have that amount of density, no problem. But in the rural area, because we have been zoned for one house, one lot. And so to change that zoning is really an enormous shift. We have no multifamily zoning, no lots in our township that are zoned to allow you to have a triplex, 4, 5, 6.
But presumably that's just a political decision that your local council has to make, no?
Well, it's a political decision, but it was also something that the province required for good reason, which was called a municipal responsibility agreement. So to have that level of density, you need to have a larger septic system, and that's called a communal septic system. And as soon as you require a communal septic system, the Ministry of Environment says to the town, okay, you will have to take that over if it ever fails. So you need to set aside money in case it fails. And no municipalities wanted to do that.
Got it. Okay, before we go to the last picture,
Yeah.
hold off on that one, Sheldon, because I want to bring Jane back in here. We've seen some alternative living arrangements here in Tay Valley Township. You got something like this in the county of Simcoe as well?
Very similar, actually, with the new development that I mentioned, Simcoe Village will be the campus name. We're developing a number of different types of housing, as I mentioned, but our new adventure is co-housing, very similar to what's been described, although it'll be one large kind of residential home that has 8 or 9 different bedrooms. They have their own washrooms, but they share living room, kitchen space, etc.
You would have called this a rooming house back in the day.
Well,
you don't, but no one likes that term anymore, right?
I call it the Golden Girls, Golden Guys model,
Okay.
and we're pretty excited because they'll develop a friendship, a safety mechanism to watch out for one another, and then have access to other services and amenities on this campus continuum. So we think it's a really innovative and exciting new option for our seniors.
And if there are 8 individual bedrooms in this larger house,
Yes.
along with the communal space of kitchen, living room, etc., does everybody own 1/8 of the property? Is that how it works?
Well, there's a couple of different models. In our model, we'll take ownership of the actual facility.
You, the county?
The county,
Okay.
and they'll rent space. But that is an option as well. We know there is co-housing where a group of individuals will purchase the facility, and then they'll each have ownership to the facility. We're going to actually take on the ownership piece and rent it to these individuals.
Because you can imagine it'd be tricky to sell 1/8 of a house, right?
Absolutely.
But if the county owns it, you get around that problem.
That's
okay.
correct.
Let's do, there we go. Okay, Noelle, this is, have I got this right? This is the cluster lot co-housing?
Yes.
Now
Yeah.
this is, again, this looks more like one continuous sort of townhomes that are all side by side by side by side, no space in between,
Right.
2 stories, nice colors again, and the advantage of this is what?
So again, within those units, you will have the shared kitchen, the shared living room, and so people can check on each other. People can not feel isolated. Social isolation is such a major concern in rural areas, especially when you have the huge geography. We don't have transit for people to be able to connect that way. So this really addresses the issue of social isolation. And again, you might think, well, that just looks like something you might see in Toronto, but it's this whole septic piece and getting the province to understand that these municipal responsibility agreements don't necessarily have to go on the back of the developer. Because if you ask a developer, are you going to build this? Yes. Okay, are you going to set aside money to replace that septic? Well, I just put in the septic. Why do I have to set aside money to replace it? So it becomes a kind of chicken and egg thing. And we're really lucky in that the county next door to us, Frontenac County, has been working with the province for about 5 years to try to make these communal systems easy and possible. And they may even come up with a public utility idea. So again, the developer wouldn't be on the hook. The municipality would use its reserves so that it would know if it needed to replace that septic 25 years down the road. It wouldn't come as a shock where you have people having to leave their homes, as you might have heard about in some, mobile home parks where the septic and the water system failed.
Now, do you have these oddities or anomalies as well, whereby you've got sort of rules on the books that prohibit slightly more dense opportunities for housing?
There are considerations in the County of Simcoe as well. Because we're building multi-residential, large campus continuums, we're not having those same challenges as the developer. We're really the developer ourselves. So we're able to work with our local municipalities to ensure that we meet the expectations from a planning perspective and ensure that in our case, we have septic, sewage and water. So we're able to, work very closely with the municipality, so it's not presenting as the same challenge.
Because one of the things that I know a lot of people in the capital city here refer to is that, we've got a subway line that goes east-west across the middle of the city, the Bloor line, Line 2. And there are huge chunks of the Bloor line where there are bylaws in place that have been there for 80 years that only permit bungalows. And, this is right, you can be living 50 feet from a subway station, and all you can build is a bungalow. And of course, nowadays, you'd want to presumably put up maybe a 3-story, 4-story, 6-story, something like that. Do you have these kind of crazy, out-of-date bylaws that prohibit?
There are different types of bylaws, but I will tell you, one of the exciting things that came out of our whole age-friendly study is the County of Simcoe renewed or developed their master plan, updated their master plan, and they actually built in an age-friendly component with symbols and guidelines for all of our area, our member municipalities. So they really tried to be proactive in the planning process, look at some of those older, dated guidelines, and really put an age-friendly spin on it to promote housing that's more suitable for our seniors.
Noelle, in our last 30 seconds, you want the province's help or you want them to get out of the way?
We want the province's help.
What do you want?
To address this municipal responsibility agreement requirement and the engineering requirements that private developers actually don't have to go through. Seems a bit ironic that a township does, but a private developer doesn't.
It does.
Yeah.
Seem ironic. There we go. I want to thank both of you for coming such long distances and fighting traffic and every other thing. Did the train leave on time?
It left on time, didn't arrive on time.
Well, such is life, such is life. Noelle Reeve, Jane Sinclair, thanks so much for joining us from Tay Valley Township and Simcoe County, or the County of Simcoe as they prefer. Great to have you here on TVO tonight.
You're welcome.
Thank
Glad
you.
to be here.
All of us who have lived through this pandemic have our own sense about whether it remains an acute health threat or something less perilous. But experts at the World Health Organization this week gave their official perspective on the matter. With us now on that, in Breckenridge, outside Denver, Colorado, Dr. Stefan Baral. He is professor of epidemiology at the Johns Hopkins School of Public Health and a population health and family physician providing care in the shelter system in Toronto. And Dr. Baral, as I welcome you to the program, I know Johns Hopkins isn't in Colorado, and I know Toronto's not in Colorado, so what are you doing in Colorado?
Well, indeed, both my wife and I as clinicians work pretty heavy during the traditional holiday season, so this is our week off that we take in lieu of the normal sort of Christmas, New Year's holiday season. So we're here on holiday and enjoying it.
Great. Glad to hear that. All right, let's set this up with the following. It's 3 years this past Monday since the WHO declared COVID-19 was a global public health emergency. And here is that organization's latest pronouncement on where we're at. It says on Monday, the expert committee determined that COVID-19, quote, continues to constitute a public health emergency of international concern, and that the COVID-19 pandemic is probably at a transition point, and that we need to navigate this transition carefully and mitigate the potential negative consequences. Okay, that's WHO speak. Can I get you to translate that into English for the rest of us?
Sure. Yeah, I think it's really important. This term PHEIC, or the Public Health Emergency of International Concern, when it's activated, it provides the WHO additional resources, both in terms of administrative resources, of funding resources, human resources, to work in terms of organizing its surveillance systems, organizing the work between countries to ensure that if new variants are emerging, that we can know about them quickly. If there are new surges, that we can know about them quickly. And I think that isn't really in place yet. And I think this sort of continuation of the FIIC at the WHO level allows them a little bit more time to, I think, finalize those things. And I think that's an important distinction between the FIIC as an administrative tool and whether it's an emergency for people, for in terms of their day-to-day lives, which I think are two very different things.
Okay, understood. But do you think we are still in the midst of a public health emergency?
I mean, I think so. I think it's a really important element. COVID will continue to represent a priority for public health departments at the municipal, provincial, federal, and international levels forever. I think similar to the work that we invest in influenza every year, COVID now is another virus in our ecosystem of viruses that we have to respond to. And I think, yes, in that sense, in the shelter system, we continue to we've sadly had somebody pass away just a few weeks ago of COVID. We've continued to occasionally send people to the hospital related to COVID. It's obviously very different than it was, but I think in terms of from a clinical perspective, from a public health perspective, it will remain a virus that we have to respond to. But I think it's really important to say that, what I tell my family is that I don't think that they have to situate their entire lives around this virus anymore. I don't think that they have to kind of plan their lives around this virus. They are protected. We've had, vaccines. We've had now most people get infected by COVID. And so I think that the way that they live their lives, they should make sure that they're taking care of their other health issues and also enjoying themselves in the way that, we do as human beings.
Let me pick up on that word protected that you just used, because presumably you think that everybody should have as many shots and boosters as is required. If there are some people out there right now who have still only had 1 or 2 shots, is that what's your view on how protected they really are at the moment?
Sure. I mean, I think at this point there's a really solid understanding that hybrid immunity, so I think it's a relatively new term, but we're calling immunity that is resultant from both the vaccine as well as from having had the infection, is really strong in terms of protecting you from severity, protecting you from going to the hospital. And I think at this point that represents the vast majority of people. And so I do think that most people are protected from going to the hospital. We do have folks that I see regularly that are on disease-modifying drugs from autoimmune conditions that are otherwise immunocompromised. And those folks, we really do encourage them to stay up to date on their vaccines. And so for some of those folks, that means as little as every 3 months between doses. But I think for the vast majority of people, having had 2 or 3 doses plus an infection is providing really sustained protection from going to the hospital. But I will note it's probably not going to protect folks from getting infected. And so if folks are testing themselves regularly, if they're having, like a mild upper respiratory tract infection, they may very well test positive for COVID at some point. But that I think it's important to separate that from what we had as when, a COVID infection really meant a very high chance of going to the hospital, or a very significant chance of going to the hospital for many people.
Mm-hmm. And if people haven't had any vaccines yet to this point, and somehow they end up seeing you, do you, for lack of a better expression, do you waste your breath on them at this point, or you just assume there's no point in trying to convince them that ship has sailed?
It's funny, I see a lot of people who haven't been vaccinated in the shelter system, and I think that is as a result of sometimes mistrust of government. It can be mistrust of the system. I don't think of it as wasting breath. I always talk to them. I've been doing that from the beginning, and some folks they absolutely don't want to talk about it, and that's okay. I don't judge them for that decision, as I don't judge them for sometimes other health conditions or other health decisions that they make. So I think it's important to sort of change the frame. I know often there's been a sort of a blaming frame for folks who haven't gotten vaccinated. I would turn it around. I use it as an opportunity. Folks sometimes will change their minds, or they don't. And I think it's important that we don't, disengage from those folks, because they may have other health needs, whether it be influenza vaccination, blood pressure control, diabetes control, mental health, et cetera. And so, indeed, I'm always up for a conversation with anybody who wants to have it.
Okay. Let me pick up on another word that you used a few moments ago, and that word was forever, as in this thing is going to be with us forever. In which case, if that's true, how does this public health emergency eventually end, or does it?
Yeah, I mean, I think that's the separation between, like the sort of the administrative or the responsibility of public health departments, where the response to COVID will never end. I think that's just an important thing. And I think we understood that very early, that this virus, given its properties, given animal reservoirs and people who don't know that they have it, and the vaccines not protecting from infection as much as severity, we understood that this was something that was never going to be eradicated or even long-term eliminated. And so I think that's an important element. That's not good news. That's just being pragmatic and realistic. I think public health departments require the resources. So, for example, in the context of this emergency in the United States, the emergency is really tied to resources. And so, the idea of access to vaccination, access to treatment is all related to it being a state of emergency. In Canada, similarly, a lot of our investments as it relates to COVID, whether it be wastewater surveillance at the shelter level, which is very useful to us, outreach vaccination service, which is very useful to us, is all sort of ending in the next couple of months. And so I think what we need to start doing is disentangling this idea of, is it a day-to-day priority for the average person, and is it a priority for public health departments? Because they require additional resources that will need to be sustained moving forward for COVID. But I don't think that the average person who has this protection really needs to worry about COVID day-to-day and make it one of their priorities that they, sort of wake up in the morning thinking about and then go to sleep thinking about.
Well, that may anticipate my next question, because I just wanted some clarification on the World Health Organization's use of the word probably, as in we are probably in a transition period. If that's the case, what are we transitioning from and to?
Sure. Yeah. I mean, I think what they are seeing right now in terms of, there's still let me just say one thing. I think, the WHO reported a number of people dying every week from COVID in that. But I think it's really important to say that there's not yet a standard in terms of how we attribute mortality related to COVID. So I think that's like one of the things that they're continuing to work on in this transition period. It's just like standardizing the definitions that we use for COVID-related mortality, COVID-related hospitalization, surveillance for new variants, and other elements. And so I think that they are transitioning to having that be really codified, having a solid understanding of that, as they do for influenza. There's a really well-established system that's been ongoing for decades as it relates to influenza. I think that's what they're transitioning to. But I also think it's really important that we be pragmatic with the population to say that COVID-19 won't go away, that I think it will continue to be something that can cause people to get sick, whether that be mild, moderate, or even severe conditions. And the best protection from that, obviously, are the vaccines that we have access to.
I gather you have said that we still have massive systemic problems as it relates to COVID-19 that we are continuing to ignore. Like what, for example?
Sure. Well, I think, we've just published a paper from Ontario showing, and I think this was understood early, that in the first few months of COVID, it affected sort of higher income folks. These were folks that were coming back from Switzerland, coming back from the US in that sort of January to March 2020 period. But it very rapidly, as does influenza and other conditions, transition to sort of local transmission related to those folks that in the context of lockdowns continue to be out working and serving, society. As needed to be, because I think without them, without internet working, without groceries being there, things would have imploded very quickly. And what we saw was, even those early waves, that we saw much higher levels of morbidity, mortality, and infection in those in lower income communities. But what's interesting to me is that that's actually the same as it is now in 2022. When we looked at this, we still see lower income communities more affected. And it's not all related to vaccination. It's related to workplace exposures, in shelter settings, in Amazon factories, people who use transit more. All of those things are related to infection risks that I think are really important to pay attention to. And I don't think that we've sort of sustained those investments. A lot of the hotels, for example, in Toronto that we use as isolation sites, tourists have come back to Toronto. They now are opening back up as hotels serving tourists and visitors. And so I think it's really important that we continue to make the investments in folks' working and living conditions that are going to help protect them, because we just haven't done that to date. In a place like Ontario, where I think we really consider equity and justice as really central to our society.
So what does that actually look like on the ground?
I think what that means is, for example, in shelter settings, we still have people sleeping 25 people to a room. And I think over the long term, we need to do better with housing programs in order to make sure that they aren't at sustained risk. In a place like that, when somebody is mildly sick, it spreads to everybody within a night, and it's really hard to prevent. We have an isolation site, a single isolation site that we use, but it's really hard to get folks to not all be affected. And again, it can cause tremendous mortality. I think in places like in these Amazon factories, I think they need to really bring in occupational health services and really think about how are the ways that we can make sure that folks are protected in their homes and in their workplaces. Again, and some of that is absolutely outreach services with vaccination programs and really encouraging folks. Some of it is also absolutely upgrading ventilation systems, looking at safer, cleaner air. And so I think it's just about bringing folks in and really thinking about this systematically. And what are these sort of systemic barriers that continue to put people in hospital related to COVID? Because I think if we do those things, I think we can really improve, COVID outcomes for the next 10 or 20 years as compared to just thinking about this sort of day to day.
Well, let me pick up on that, because, of course, the COVID-19 that people may contract today is certainly not the same COVID-19 that they might have contracted 2 or 3 years ago. Do we know enough yet about the level of immunity people can get through the mixture of vaccines and previous exposure? Do we have an adequate amount of information about that yet?
I mean, I think collectively, so we've published on this, I think others have. I will say this, that COVID is the most studied virus in history. It's the most studied health condition in history. I think at this point, there's been almost 400,000 papers related to COVID. So I will say we have a lot of information that we can work with. And I think the best information that we have is that people who have had infection and who have had vaccines are really well protected. But I also think it's really important to say that there are folks that are immunocompromised that require ongoing vaccination and may require additional sort of protections that would include high quality masks for themselves to make sure that they're protected from these settings. So I think that's an important thing, that we in modern medicine can't protect everybody in the same way. And I think we need to sort of make sure that those folks have additional services in terms of outreach vaccination, encouraging them, those folks that are in high exposure occupation, again, going out to them, having those outreach services, or at least making sure that when they're seeing their family doctors, that they, that they receive protections via management of their chronic conditions. So one of the things that we know, for example, is that people with uncontrolled diabetes, uncontrolled hypertension are more likely to end up in hospital from COVID. People with uncontrolled chronic obstructive pulmonary disease can end up in hospital from COVID. And so I think what it speaks to is, like, we have to do better with linking people to family doctors, moving away from walk-in clinics. All of those things that are sort of central to our health system are actually also going to improve COVID outcomes.
And is there any reason to believe that vaccines might actually become more efficacious as time goes on?
I think that's a fair question. I think there's a lot of production of new vaccines as we speak. I think there was something like 100 products being evaluated. I will say that I think for the vast majority of people, the mRNA vaccines, especially for older, more immunocompromised people, have provided great protection. And I'll say, in the pre-vaccine era, when we were responding to outbreaks in the shelter setting, we would have huge outbreaks and we would send large numbers of people to the hospital. It was immediately different. We started vaccinating in about January of 21 in the shelter setting. And you could immediately see that the shelters that had been vaccinated, even if there was an outbreak, it was unlikely that we would send people to the hospital, and it just was a very different dynamic. There was much less transmission overall. And so I think that the vaccines may get better. Obviously, pharmaceutical companies are actively working on this. But I do think that we have the vaccines, the original vaccines, even the wild-type vaccines are providing great protection. Again, in the context that now most people have also been infected with COVID. Not everybody.
Okay, let me drill down a little deeper on that one, because, of course, again, going back to this theme that the COVID of today is not the same thing as the COVID of yesteryear. We have different strains, we have different subvariants, we have different subtypes. How concerned are you that whatever vaccinations are being produced right now or in the future may not actually be as effective because this thing just keeps mutating all the time?
Sure. Yeah, I mean, I think it's really important to say, I don't pay as much attention to the variants in a broad sense, like in a day-to-day sense, as some other folks. I think that this is a virus that will continue mutating and changing over its lifespan, similar to influenza and other coronaviruses. I don't think we've ever sequenced other coronaviruses this closely. So, while we have these traditional waves of coronavirus, sort of the seasonality of coronaviruses, we've never sequenced it this closely. And so but I think that we would see that it also was full of new variants, every year affecting us. So I've sort of separated that idea from, this idea of like what is putting, ultimately for me, it's what is resulting in somebody going to the hospital. And I just don't think that with these new variants that we're whether it be the virus changing or just us changing in terms of increased immunity, we're just not seeing the same level of hospitalization. And that can change. And if it does change, then I think we have to react differently and act differently. But we've not seen it change anywhere in the world, ranging, from, I should say, outside of China, where they've just sort of had their initial waves that we experienced a couple of years ago. We've just not seen the places that have already had these large waves have large waves that have resulted in significant morbidity and mortality, which I think is what most people are paying attention to.
So in our last 30 seconds here, is the long-range plan to have COVID become just like the flu, where basically we know it's coming every year, we're going to get our fall shot or our winter shot, and life goes on?
Yeah, and I think it's really important to say, so broadly, yes. I think that the same way that we see public health responding to influenza with their seasonal campaigns, we are going to see them saying like it is influenza and COVID season. I think this question about annual shots is something that we need better research for. We have that research for influenza. We need to ask that question, whether that is going to result in the same sort of benefits for people. But broadly, yes, public health is going to have to react and respond to COVID. I think maybe I'd say unfortunately, but realistically, for as long as we all are alive.
Gotcha. Dr. Stefan Barral, we are really grateful that you could spend some time with us, taking you away from your vacation to share this very important information with our viewers and listeners. So thanks so much.
It was a pleasure. Thanks for having me.
And that is the agenda for Wednesday, February 1st, 2023. Tomorrow, we'll look at the recent spate of violence on Toronto Transit, and we'll recall the life of advocate, role model, and former Ontario Lieutenant Governor David Onley. I'm Steve Paikin. Thanks for watching TVO, for joining us online at TVO.org, and we'll see you again tomorrow.
The Agenda with Steve Paikin is made possible through generous philanthropic contributions from viewers like you. Thank you for supporting TVO's journalism.